Hi, my name is Francisco Murillo. My topic is liberal and conservative oxygen therapy for acute respiratory distress syndrome. Definition: acute respiratory distress syndrome is a condition characterized by a remain of fluid in the air sac of the lung that does not allow oxygen to reach the organs. In most patients with ARDC, high levels of inspired oxygen are warranted in order to make adequate oxygenation.
And now let's take this video.
Some of the patients you will encounter may develop acute respiratory distress syndrome, also known as ARDS. In ARDS, the affected part of the lung is not the airways. Rather, the affected part of the lung is at the alveolar level. ARDS is caused by leaking of fluids into the tiny alveolar sacs of the lungs. So, for example, here is one magnified alveolus. And normally, oxygen that is inhaled into the alveolus is supposed to diffuse into the blood so that the blood can deliver the oxygen to the body. But in ARDS, fluids fill the air sac. The integrity of some of the alveoli will be compromised, often leading to alveolar collapse or atelectasis, and this will ultimately compromise gas exchange. So as a result of diffuse alveolar collapse, the lung will appear to shrink on a chest X-ray film. Collapsed alveoli may also result in refractory hypoxemia. Refractory hypoxemia is hypoxemia that does not correct with the administration of supplemental oxygen. In other words, you can try to administer high levels of FiO2, but because the alveolus is collapsed and compromised, oxygen concentration alone will not correct the hypoxemia. Correcting refractory hypoxemia will require a recruitment of the alveolus, which is a reopening or a restabilizing of the collapsed alveolus. The oxygenation status of the patient is also one of the ways in which we classify the severity of ARDS. So to determine the oxygenation status, the clinician should perform the PF ratio, which is simply the PaO2 divided by the FiO2 of the patient. Here you can see the classification of the severity of ARDS, as well as the mortality risk. So improving oxygenation will be one of the challenges in treating ARDS. But how can we get oxygen in if patients with ARDS have a difficult time getting volume into their lungs due to the fact that the alveoli are collapsed? Reopening collapsed alveoli will require an immense amount of patient effort. Additionally, the lung will tend to recoil upon inhalation. In other words, even if the patient does inhale volume, the lung will immediately want to recoil and exhale. This ultimately leads to shallow and rapid breathing. So that begs the question, what are some strategies in modifying our ventilator settings and treating patients with ARDS? And the answer to this question is coming up in the next lessons, so stay tuned.
Application in medicine. The practice of oxygen administration has been liberal, possibly resulting in the administration of too much oxygen, now and hyperoxia. Despite the lack of several evidence regarding difficult oxygen administration has been widely recommended in the international wildlife for the clinical practice. But some clinical studies, but not all, have indicated a relationship between hyperoxemia and an increased risk of death. Conservative and liberal. At the 19th offered the start simultaneous liberal and conservative oxygen. Mortality was significantly higher in the conservative oxygen group than in the liberal oxygen. For example, some clinical studies say 5 mesenteric ischemic events occurring in the conservative oxygen group and none occurring in the liberal oxygen group. Pros and cons. First, what we know about oxygen is oxygen does not help, but the way it will not harm or not is fact oxygen in the part of therapeutic syndrome care protocols. The oxygen administered doctor ensure a SpO2 of 96%. Pros and cons. Pros might decrease the lung demand and the air space on the disease. Ensure intrathoracic pressure. Cons. According in the group the patient with conservative oxygen. In the patient with sepsis, there was signal for higher mortality in the group exposed to conservative oxygenation. Using applied in Ecuador, the problem lies the pandemic that struck the world, COVID-19. Coronavirus can cause ARDC, so we can fall in the syndrome that we need therapy with drugs and course give help our respiratory system. Many people need oxygen, but the question is there the risk will be worse is because that is not guaranteeing success, but in my opinion we can have to take the risk.
Now let's see this video.
Hey guys, welcome back to the Critical Care Survival Guide. One of the things that's changed in the last few weeks with COVID-19 is volume of patients. A couple weeks ago, we just had a handful. And as I was starting to see more and more patients come in, I thought to myself, how am I going to organize my thinking? How am I going to organize my planning on these patients so that I can be efficient, particularly as the volumes go up and up and up? Here are some strategies that I've discovered that really seem to work for me. When I first encounter a patient, I want to get the timeline. When did they first start having symptoms? I want to hear about known contacts because that will increase the likelihood that they have COVID-19. I want to know specifically if they have cough, short of breath, any GI symptoms. This loss of taste and smell is another interesting question I've been asking. Establishing the timeline helps me predict when they're going to become more and more critically ill, needing hospitalization or ICU care. After I've established the timeline and I've made the decision to admit the patient, I need to decide how I'm going to adjust my plans each day. And I'm going to adjust those plans based on data. So what are the things I'm looking for? Well, for starters, I want to pay very close attention to their oxygen needs. Not only the FiO2 or the amount of oxygen they're getting, but also what's their respiratory rate. I've been paying particularly close attention to their FiO2 and their PaO2. The ratio, the P to F ratio as it's called, is an important way that you can see how someone's progressing with the disease. Ratios that are going up, it's a sign that the patient is improving. After I've looked at their oxygen, I want to get a better idea for their systemic inflammation. We know as COVID-19 gets worse, inflammatory markers go up. And studying that elevation in inflammatory markers may portend a worse prognosis. So some of the markers I'm watching in particular and ordering every day so I can pay attention to it include ferritin levels, C-reactive protein or CRP, their D-dimer level, their lymphocyte count, specifically because patients with COVID-19 have low absolute lymphocyte counts. And I've noticed as they improve, those counts improve as well. In addition, I'm watching obviously their creatinine, their hemoglobin, and as you would on any patient every day, their eyes and nose I follow very strictly.
Conclusion. In conclusion, among patients with ARDC, early expression to a conservative of liberal oxygenation strategy can be successful in some patients, but in worrisome severe signal was observed in the group assigned to a lower oxygen exposure. The meaning of this signal to clinical practice is unclear. Thank you.